And then yeah. Okay, now we're recording. Okay. I'm not like videos or something, but right now I'm working on a learning star.
Awesome.
I'm Rackow, care coordinator.
Sorry, your neighbor.
I'm Renee.
Huh?
I'm Dr. Renee, care coordinator, but I'm trained for facilitation.
Awesome.
Hi, I'm Denise. Right now, training Dr. Bishop.
Awesome.
Hi, I'm Liana. I'm training, hopefully, for Dr. Bishop.
Awesome. Great. Nice to re-meet, meet all of you. Awesome. All right. And hello to everyone who's all right. You just get started. Right.
Absolutely. I want to know, like, I think you've seen this at school, how lucky we are extraordinary experts, so many different fields. Today is a shining example. It's true. You go around the world and you talk about the complexity. There's usually the school of surgery and there's the school of cardiology. And it's really rare that somebody who straddles both so well and provides such great expertise and can approach patients in such a fashion to really understand the reproductive concerns in the future as well as the surgical ones in the immediate moment. So it's really a great privilege to have Dr. Rackow as such an important part of this UFC team. And thank you again for taking the time to share some of your wisdom.
All right, my pleasure. So for those of you who haven't officially met me before, I'm Rackow. I've been around a while. This is, I think, 14 years here at Columbia. And I have a unique job. So I straddle two different divisions. So I am part-time with CUFC, even though I'm 100% time here and 100% time in my other job is what it feels like. But I'm also part-time with the division of gynecologic specialty surgery. Because as part of my training and my love and my expertise, it's within reproductive surgery. I also, as an aside, as part of my GYN surgery practice, do take care of pediatric and adolescent patients as well. So I wear a few different hats. But anyways, when I'm here at UFC, I'm seeing like the broad spectrum of fertility patients and provide full range of fertility services. But I also do a lot of the surgery for patients from this practice, patients who need advanced procedures that can't really be done here at the office, need different deeper anesthesia, different techniques, different availabilities of things. Hello there. So I tend to see a lot of patients. And so especially for those of you who are care coordinators, a lot of you are sending referrals, even though it sort of feels weird that you're sending them to me, but you sort of go through my GYN surgery practice. All my surgery is done through that practice. But I have a process where I'll individually contact patients, reach out to them, help them schedule surgery. And my goal is to get them onto my schedule as soon as possible to get their procedures done and then get them back to the fertility center, back to their provider who referred them to me to get them going back into whatever treatment they need. So most people think this is how I spend my days. For those of you who remember the good old game of Operation, I have a 6.5-year-old son, and someone gave him this game. It's freaking hard. It's really hard. They give you the worst possible instrument, these little forceps that don't even work to even try to get these out. I do not do well at this game. But anyways, I love having this game on our shelf because it would make me happy to think about, this is the fun side of what people think I do. All right, so the tenets of reproductive surgery. We know that and I know that you guys have learned about the infertility evaluation, right? And also management, IVF, PGT, et cetera. So part of what makes us successful in terms of managing patients with fertility concerns, having a normal uterus, a normal uterine or endometrial cavity, healthy fallopian tubes, and a healthy normal pelvis is important to maximize the chance of a successful pregnancy. Any disorder that causes the uterine cavity to be abnormal is associated with a decreased risk of decreased chance of embryo implantation and an increased risk of miscarriage. So we're going to spend a lot of time going through normal and abnormal and what I see and what we work on. The reason I'm doing slides and not a chalk talk is you'll see really quickly, I have a gazillion photos and images that I think makes it really helpful for you to understand what does a normal saline sonogram look like and what does it mean when there's something abnormal and how do we approach this. So any surgery lecture sort of needs, I don't have videos, but just a lot of photos. So the goal of reproductive surgery is to normalize pelvic anatomy and both preserve or improve the chances of a successful pregnancy. So for fertility workup, you know, the number 1, 2, and 3 thing we're doing is a comprehensive patient history. And then for every patient, we're doing some component of pelvic evaluation. That tends to start with mostly a transvaginal pelvic ultrasound. There are the select patients who are going transabdominal only, either like the adolescents who are coming through for fertility preservation for different reasons, patients who just for whatever reason, like, can't tolerate a vaginal ultrasound, but we tend to be doing mostly transvaginal pelvic ultrasounds, the hysterosalpingogram or HSG, which helps us evaluate the cavity of the uterus and the fallopian tubes. But as we talk about, it really only shows us a portion of the pelvic anatomy. The sonar histogram or saline infusion sonogram, or FHD as we call it around here, is another way of looking at both the cavity, the inside of the uterus, as well as the muscle of the uterus and things outside the uterus. And then a pelvic MRI or magnetic resonance imaging, which is something that we're going to that extent for someone who has certain conditions by which we need further, more dedicated, detailed imaging. Often with things like fibroids, endometriosis, certain congenital or birth defects of the uterus. Okay, so let's first talk about normal. I know this is a busy slide, but I think it's important to understand. So here on the left, if you can see my cursor, so this is like the view, what we call a sagittal view. We're looking at the top of the uterus here. This is looking through the uterus, the cervix and vagina are down here. So this is like, we're almost like bisecting the patient. If you sort of draw a line down someone's like they're like down the middle of their body, and when we're looking from the side, like that's the view of the uterus. And so the muscle, the myometrium, is this darker gray area here. And the endometrial cavity or endometrium is this brighter white stripes. We call this like the endometrial stripe, the endometrial thickness. When we're measuring this in the setting of fertility treatment, we're getting what we call the sagittal view, and then we're measuring from one wall of the uterus across to the other. Interestingly, like if this was a 10 millimeter lining, it's really 5 millimeters on one wall and 5 millimeters on the other wall, and we add them, and they just get added together based on how we measure. But this is like our standard view of the uterus. Now, one of the things that we have the ability to do, and Roma, our PA, is amazing at getting these views, is using a special probe to get a three-dimensional view of the uterus. So that's the only way that we can get what's called this coronal plane. So for this plane, it's almost like we're bisecting somebody like across the top of our heads and straight down through our body. So we're getting this front view of the uterus. And so here we can beautifully see the outline of the uterus, which is sort of this upside down triangle. Again, out here is the myometrium that completely surrounds the endometrial cavity, which is sort of this upside down triangle. And what we want to see, like, this is a nice smooth top of the uterus, nice smooth lateral wall. This corner is going out toward the left corner of the uterus and then reaching the fallopian tube. This is the right corner. And so this view really helps us understand the shape of the uterus in a different view. And again, it's our typical like morning monitoring ultrasounds can't get this view. We need a special probe to get this. And then the hysterosalpingogram here, the radiologist is putting this dye inside the uterine cavity. So places some dye in the uterus so that we watch this dye fill and spill out the fallopian tubes. This is a poor, like an imperfect representation of the uterine cavity, because right, the uterus is a three-dimensional structure, and we're just getting a two-dimensional view of it in this one plane. So that's one of the reasons an HSG gives us a limited view of the uterus. It's much better viewing the fallopian tubes, which we want to see the dye fill and spill out the tubes. However, say we see an abnormal HSG where there's what we call a filling defect. All we can tell is that there's a place where this dye, which shows up bright white, just doesn't go. But we don't know what that is. And that's when we need other like radiologic imaging to help us see what that bump is, like what's making dye not fill a certain area. But here you can see we're seeing this nice upside down triangle shape of the uterus, similar to what we're seeing on the 3D ultrasound here. And then the saline sonogram, instead of putting like the HSG, we put dye inside the uterus and take x-rays at the radiology office. Here, we're just putting water inside the uterus. Now, and on ultrasound, like simple fluid or water or saline just looks black. So you can see how here, like the uterine cavity is a potential space. We only see the cavity when there's something inside of it, be it dye or water or maybe a pregnancy. But here we can see nicely this water fills the uterine cavity, and now we can really see like the uterine lining is the thin lining around the walls here. And here we can see nicely the muscle, and we can see this nice smooth cavity, which is what we want to see. And this is the three-dimensional view, again, requiring that 3D probe to get this nice upside-down triangle view of a uterine cavity. So hopefully this just gives you a sense of what we're looking at when we think of normal. So if someone has a normal HSG, like this is the images that they're getting, or a normal saline sonogram, because we're going to take a deep dive into other times that this is not normal. So I think having a solid knowledge of normal is important. All right, so we're going to talk about endometrial polyps, uterine myomas or fibroids, uterine septum, intrauterine adhesions, hydrosalpinx, endometriosis and pelvic pain and ovarian stuff. We'll talk about each of those in turn. I know they gave me like 30 minutes for this, and I'm sure we'll be here a little bit longer. So as we're approaching these, like the most common procedure that we're doing to evaluate things that are inside the uterus, we'll talk about laparoscopy second, but we're doing this procedure called hysteroscopy. Basically, we do this here in the office, but when we do this in the office at the end of our egg retrieval days, this is just done under the same conscious sedation. So we only have a certain amount of time under that anesthesia to get this procedure done. So we do a lot of these simple procedures here. And for any of you who want to see these procedures, be it as you're meeting, we're familiar with what we do, see egg retrieval, see hysteroscopies. It's always easy to catch up with either the doc of the day or when your doctor is the doc of the day, putting on scrubs and coming down. Like my care coordinator's done this before over the years, and it's fun to just sort of like just see what some of these procedures are and see some hysteroscopies and see what the inside of the uterus is. It's really cool. So basically, a hysteroscope has this is the scope, the camera that's attached to a light cord, and at the end of this part here, there's a camera feed that goes to a video screen. So the scope is looking inside the uterus, but the feed is to a video screen, which is why you can see everything that we're seeing on the inside. And then we have fluid that goes in, flushes into the uterus to help us see, as well as outflow to suction out any blood or debris. And then by putting fluid inside the uterus, we expand those walls so we can see. And then with the aid of a light source, we're able to distend and look inside the uterus to find anything that looks abnormal. So first, let's talk about endometrial polyps. So polyps are benign, 99.5% benign overgrowths of the uterine lining. Super common. Like 25% of women have these, and for many women, they have no symptoms whatsoever. But some women can present with bleeding in between their periods. They can have heavier menstrual flow. The question is, do they have any impact on fertility? Well, as we've talked about, anything that's wrong with the uterine cavity could impair an embryo from implanting. But many women are asymptomatic. And some can have one endometrial polyp, or they can have multiple. So sometimes on a plain two-dimensional ultrasound, we start to question whether there's like this very focal, like brighter white area that we're seeing here inside the uterus that looks like maybe it shouldn't be there. Because if we go back to our normal uterus, like here we're just seeing sort of a very symmetric, all the tissue looks the same. And here we're seeing like that tissue looks the same down here, and then like this white area that's more focal. When we do a saline sonogram, we put that water inside the uterus, right? The water fills the normal cavity and surrounds this abnormal growth that's there. So here you can see one larger endometrial polyp, and here you can see someone who has a few different polyps. These can be small, 2, 3, 4 millimeters in size. They can be large, like 2 centimeters in size, and everything in between. And someone can have one, someone can have multiple. And so these are some surgical photos. And I warn you, I have surgical photos for everything, which some people it makes them feel a little bit weird, but I don't, not really eating lunch right now. But nothing is really gross or gory. These are all just like normal findings, but they do have photos of pretty much everything. So this is looking inside a uterine cavity, and all this pink tissue is the normal endometrium. And here you can see like this is all smooth around here, but then you see this, like this thing that shouldn't be there. So this is what a polyp looks like. And then here you can see this is the polyp here, and then this is the base of it where it's attaching to the normal uterine wall. And here you can see these are some little scissors that we can advance instruments through the hysteroscope and use these scissors to either cut the base of the polyp to then release it from the uterine wall, and then we remove it, and any tissue that comes out of a patient gets looked at under the microscope by a pathologist to make sure that we know what the tissue is, that it's benign, and that there's no chance of there being some abnormal, like potentially precancerous cells on a polyp, which is rare. But again, any tissue like in surgery that comes out of someone always gets assessed. So here you can see like, this is one polyp here, this is a bigger polyp, and we're cutting at this base. And usually the uterus heals really well after these procedures. Like if I remove polyps 1 month, the next month someone usually can turn around and start a fertility treatment right away without needing to do any further imaging, depending on the situation. All right, so uterine myomas or fibroids. So fibroids are, again, like 99.5% benign growths, now not of the uterine lining, which is a polyp, of the uterine muscle. And each of these growths starts out as one single muscle cell that grows and grows and grows and hypertrophies. And these fibroids can have a lot of different locations, and the symptoms related to fibroids are based on both the number of fibroids someone has, one or multiple, the size of them, and the location. So the location matters because here we're seeing this here is the uterine cavity that you've seen some images of. So here's a fibroid that's growing completely inside the cavity of the uterus, just sort of hanging out in there, called submucosal fibroid or intercavitary. Here's a fibroid that's growing. It's originating from the muscle, this lighter pink area, but you can see it's growing into the cavity and distorting the endometrium here. This is called the submucosal fibroid. These can definitely impair both an embryo from implanting and can increase someone's risk of miscarriage. Now, patients may have fibroids that are what we call intramural, meaning they just grow within the myometrial layers. They're just growing in the muscle. They can be what we call subserosal, where they're growing in the muscle, but really just pushing on that outer layer called the serosa of the uterus. Some can be what we call pedunculated, just hanging off the uterus by a little stalk. So we're not as worried about these intramural or in the muscle fibroids or subserosal fibroids unless someone has so many of them that it makes their uterus really large. And thus we worry about lots of fibroids could really distort the contour of the uterine cavity and also cause issues with fertility. So patients who have fibroids, and many have no symptoms at all, these are super common, and these are the most common benign growth in a woman's reproductive tract. Like more than 50% of women in their life will have a fibroid. And symptoms can include heavier periods. Some people have prolonged bleeding. So say they used to bleed for 5 days and now they bleed for 7 to 9 days. They may bleed in between their period. Some women may have some more pelvic pain and cramps with their cycles or dysmenorrhea, painful periods. Sometimes these fibroids, based on the location or the size, can press on someone's bladder and make them pee a lot, or press on someone's bowel and cause some pelvic discomfort or like constipation. Again, it's something that we see in the infertility population. And then especially fibroids that distort the cavity of the uterus, we can see higher risk of like pregnancy loss, miscarriage, or complications during pregnancy. So this is a saline sonogram, and different than the polyp, you can see how this growth is a bit more circular, And it almost looks very similar to what the muscle of the uterus looks like, but yet you can make out this circle, this ball, and you can see how this fibroid, which is a submucosal fibroid, is growing into and distorting the uterine cavity. So it looks different than that nice normal cavity. We should see these smooth walls all the way around, and we don't. Here at hysteroscopy, you can see, so this is like a fibroid, this ball of muscle that's growing into the uterus, and here you can see another one causing distortion. So these require, because these are denser tissue, almost like these balls of muscle. So we need to use the different instrument called a resectoscope. And for this procedure, we use some electricity, some energy, and this device that shaves out the fibroid. Polyps are squishy and soft. They're easier to get with some different instruments. And here, we need this resectoscope with this device with some energy. So here you can see, so it's this loop. And then here you can see, like, this is the contour of the fibroid. You can see there's like this gouge in it because this loop has just been taken to swipe at a piece of the tissue, and then we keep swiping all the way down to get the entirety or as much as we can of this fibroid out. So this usually has to come out in pieces. But again, all those pieces get sent to the lab to confirm what we're looking at. Now, I think I have a more graphic photo next. So here, this here on the left is an MRI. So for someone who has a bigger uterus, or we're trying to understand how many fibroids they are, what the size of them are, we sometimes need better imaging beyond just ultrasound. So here, this is a uterus here, and all of these gray circles, dark gray circles or blackish circles, these are all fibroids. This here is the uterine cavity that you can see. You can see fibroid here, 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 even here. And so someone who has a really large uterus, these fibroids might be recommended to be removed either through an open surgery on their belly, through an open cut, which is what you're seeing here, or more and more commonly, these patients are having minimally invasive surgery, which is being done through a laparoscopic or robotic route. But here you can see, so this, you can see there's a big fibroid here. This is a big fibroid sticking out. These are two little fibroids. So this is a uterus before the fibroids have been removed, and then after. These are just sutures where fibroids have been removed and the uterus has been sort of sutured back together in many, many layers to get the uterus back to normal. And the uterus shrinks down over a few months. Because of all the stitching that needs to happen for these procedures, these patients cannot conceive for at least 3 to 4 months because we need that uterus to heal, no matter how an abdominal or laparoscopic myomectomy was done, before someone gets pregnant and then that uterus stretches all over again. So someone needs 3 to 4 and sometimes as long as 6 months. The hard thing for us is we often have like a 40-year-old who's about to have surgery for fibroids, and we don't want them to wait too long and get, those are precious years. So sometimes these patients are doing IVF before this kind of surgery to collect some embryos and then having the surgery they need, and then waiting 3 to 6 months for uterine healing and then going to get pregnant. Because it would be really hard for someone who's 40 to have the surgery and wait up to 6 months before they can even try to get pregnant.
Could they do could they say they have a poor outcome that they do another IVF cycle while they're healing?
Absolutely, good point. So what we're not using a uterus, right? When someone's going through IVF, we're just working with the ovaries. So someone absolutely could do an IVF cycle, like, starting like a month or 2 after a myomectomy procedure, as they're waiting for the uterine healing time before they can actually have an embryo transfer. All right, so moving topics, we're going to talk about uterine anomalies. I'm actually going to jump forward a little bit. And I'm going to go back. So uterine anomalies, or what we call congenital anomalies of the reproductive tract, otherwise known as Mullerian anomalies. These are, sort of birth defects of how the uterus develops when a woman is inside her mom. Because the uterus develops starting around 5-6 weeks of gestation really early on, and it's fully developed by 20 weeks of gestation. So about halfway through pregnancy, the reproductive system is fully developed. And the way the system develops is it develops as these 2 separate ducts that are these solid tissues that here meet in the middle. And then these solid ducts, both the inner part of the ducts becomes hollow, but then there's still this midline septum that resorbs. And then eventually we develop this sort of upside down triangle portion of the uterine muscle with the uterine cavity. And then all of this tissue that forms the uterus and cervix also joins tissue that forms the vagina. So lots of things can go wrong in terms of how these ducts develop. So we see patients who have a condition called Mullerian agenesis, where I have a number of these patients in my practice. I will write all over the chart, patient does not have a uterus. And patients are born sometimes where these ducts never developed. So they have no uterus, no cervix, sometimes no vagina, and they have to like dilate their tissue to create a vagina. And these patients would either need a surrogate to help them have a baby, or this new field of uterine transplant is something that's available, but still like in research. If only one of these ducts develops and not both, patients will end up with a unicornuate uterus where like we only see one side of the uterus, right? If you go back, so this is normal down here on the left. So if only one side develops, these patients almost have like half a normal vagina, cervix, half a uterus, one fallopian tube. The ovaries are normal in all of these patients because the development of an ovary is separate from the development of the uterus and cervix and vagina. If these two ducts start to develop, but they never meet in the middle, the way the picture is showing here, you can have a uterus didelphys where they have two half uteruses, two cervixes. They have a fallopian tube coming off each side. And for a lot of these anomalies we're talking about, they don't necessarily cause infertility, but they can cause issues with recurrent miscarriage, pregnancy loss, other pregnancy complications. Someone who has a bicornuate uterus, for these two ducts partially fuse in the middle, but not completely. So you can see like the outer part of the uterus looks normal down below, but up top there's a deep divot at the top of the muscle, and the uterine cavities can be either totally separate or they can be conjoined partially. And then what we're going to talk about next is a septate uterus. So this is what we see most commonly. This is at least, like this could be as high as 5 to 10% of the fertility population. And for this, the uterus form, the muscle forms completely normal, but this midline division of tissue just doesn't fully resorb. And someone can have a complete uterine septum where the entirety of this tissue, like this midline division, just never resorbs, or they can have a partial septum where it only divides the top of the uterine cavity, but not the lower uterus, the cervix, or the vagina. And this other condition, arcuate, is really considered a variation of normal and is not of concern. So we see patients who may not have any history with pregnancy loss or issues, but as part of our fertility workup, we can identify that they may have a partial uterine septum or a complete uterine septum. A uterine septum is the one uterine anomaly that can be fixed. These others, that you can't really put these uteruses back together easily. It's a pretty tough surgery to go through and doesn't guarantee them better chances of a healthy pregnancy. But a uterine septum is a very straightforward surgery that we can basically cut through this extra tissue to get the uterus back to that of a normal shape. So this is showing again another photo of what we call a partial uterine septum, where part of the uterus is still joined together, and then the upper part is divided into two. We can sometimes sense this is present by both that 3D ultrasound shows nice smooth muscle at the top and this deep V. And you can see this uterine cavity is sort of separated into two, like a peace sign. And here, sometimes we start to pick this up on HSG. So on the X-ray test, it can show that there's this deep division. Interestingly, because the X-ray test doesn't show us where the uterine muscle is, you have no idea, if we go back to here, if this patient has a partial bicornuate uterus or a partial uterine septum, those cavities can look the same. So that is why when we see someone with any sort of irregular uterus on HSG, we have to go make sure that we have usually a good three-dimensional ultrasound and sometimes a saline infusion ultrasound to really understand the cavity and understand where the muscle is, because an HSG doesn't show us the outer contour of the uterus. So patients with a uterine septum, a lot of them have no symptoms whatsoever. They had no idea. Some people might have a history of recurrent pregnancy loss, some pregnancy complications like preterm labor, preterm delivery, babies being born breech and needing a C-section to deliver them, meaning some babies coming out like butt first or feet first, and we don't let those babies deliver vaginally from that position. Some of these patients have a history of like wanting an IUD for contraception or menstrual control, and it like either perforated the uterus, goes through the wall of the uterus, or it won't stay in place and it becomes malpositioned or expelled because no one knew that they had an unusually shaped uterus. And an IUD is like a T-shaped device, which is meant to fit in the shape of a normal uterus. If you think of that upside down triangle, it did not fit inside someone with any of these uterine anomalies. And I see a lot of patients at my GYN practice who had issues with IUDs, and that's how people found out that they had a variation of how their uterus developed. Some of these patients might have heavier menstrual periods, painful periods. There's some question about that in research. But again, most people have no symptoms whatsoever. And so what we do is here we're taking a look inside the uterus, and we're looking at this midline tissue, which is the septum. So when you think about it, we're like the hysteroscopy looks like from the cervix up into the uterus, and we're staring at this midline tissue, and we're staring and we can see the cavity to the patient's right and the cavity to the patient's left. So here's that midline tissue, cavity to the patient's right, cavity to the patient's left. We take these tiny little scissors and we start cutting back and forth like through this tissue, and this tissue is like doesn't have a whole lot of blood supply. It's sort of this more fibrous tissue, and at the end you can see that here we've sort of cut across the septum here. Like we started all the way like at the tip and we cut all the way to the top of the uterus. And now you can see from one corner of the uterus all the way across to the other. And then the uterus heals with this new configuration. It's my practice to put a small little balloon inside the uterus that stays in place for 5 days, just to make sure that the tissue doesn't stick back together where we did any cutting. And I just take that out in the office. I think knowing that I'm leaving something in place always freaks people out, but it doesn't. It causes some cramping while that's in place, and we take it out in the office, and it doesn't hurt to take it out, or I sometimes do them here as well. But then hope the uterus should heal back to a normal shape, and then we typically do a three-dimensional ultrasound a month later, make sure that the uterus is back to a more normal shape, and then they can move on to their treatment. And because the septum is associated with a higher risk of pregnancy complications like miscarriage and preterm labor, preterm delivery, research has shown that fixing the septum often takes those pregnancy risks back to that of the population of those who have a healthy, normal shaped, typical shaped uterus. So that's why for us, we are very adamant about trying to fix uterine septums in our infertility patients, because our infertility patients have a higher risk of miscarriage to begin with, right? They tend to be a little bit older, which increases your risk of infertility. Going through fertility treatment, like IUI and IVF, comes with a higher risk of miscarriage anyways. And we don't want to leave in place a congenital disorder of the uterus that further increases someone's risk of miscarriage. So the reasons we fix this, again, and I see patients who come to see me, they haven't even tried to get pregnant, but they know they have a septum, they're freaked out about the risks and want it fixed. So that's sort of elective, like making the decision to get it fixed. But for other patients, our fertility patients, because of their advanced age or pursuing infertility treatment or having a history of a miscarriage, those are all reasons to fix this as someone's pursuing fertility treatment. So I fix a lot of septums each week. All right. But hopefully that also helps, because you guys are going to see, your doctors on your team talk about, oh, this patient has a unicorn uterus, this patient has a type delta, this data, this or that. And these are all these variations of uterine development. All right, changing conversations over to uterine adhesions or intrauterine scar tissue. So these form based on some history of trauma. So this doesn't really happen unless someone has had a procedure inside the uterus. So it could happen if potentially patients don't heal well after removing fibroids or polyps or uterine septa. It can happen after someone's had D&Cs, either for miscarriages or pregnancy terminations. It can happen after patients had C-sections. So any surgery inside the uterus puts the uterus at risk of trauma and at risk of scar tissue forming, where potentially some raw edges of the uterine wall stick together. Sometimes we question if this is present based on an ultrasound, where we can see that there's like uterine lining and then there's like a space and then more uterine lining. And we start to wonder, like, does that mean that someone has some scar tissue? We typically pick this up either on an HSG, where they say like there's like a filling defect in the uterine hole, like there's an area where the dye doesn't go that looks abnormal, or here is a saline sonogram where you can see there's fluid into the uterus, and then there's this band where it looks like this is the posterior, the back wall of the uterus is attached to the front wall, and then there's fluid up top. For many of these patients, they have no symptoms, but some might have later periods than they used to have because there's less normal healthy tissue to menstruate. The worst of cases, patients may have amenorrhea or pelvic pain where they're not menstruating at all because either their menstruation is totally blocked by lots of scar tissue, or they have very little normal endometrium or uterine lining to bleed. Some of our patients will just show up with infertility or history of pregnancy loss or other pregnancy complications. So when we're looking inside the uterus, if you go back and think about like here, isn't the best picture, but like a normal uterus, like you see this nice healthy pink tissue, like here you can see minus where we operated, like normal healthy open uterine cavity. If we go and look at someone with adhesions, you almost see like these cobwebs, like all these bands that can be like, but down below here, those bands are really thick, and up above these bands are more filmy, just distorting the uterus. And so we have to gently, carefully cut through these bands of scar tissue to get the uterus back to a normal shape. And then I should change this picture. This is like the older style stent or balloon that I used to leave in the uterus that was perfectly shaped like an upside down triangle that fit inside the uterus nicely. And then the company decided to stop making it. So now I use a balloon that's a bit more of a circle, but it still works really well. We only put a tiny bit of fluid inside the uterus. Inside this balloon, like the uterus actually can't stand very much fluid inside this balloon, otherwise it causes a lot of pain. And then and this again stays inside the uterus for 5 to 7 days, because when you cut scar tissue, there's like now these raw edges, and you don't want them to touch each other. You want the uterus to heal with healthy uterine lining over those raw edges. So that's really important that you both prevent those raw edges from touching each other. That's why the balloon is there. But then the other thing we do for patients with adhesions is we really want to encourage normal, healthy uterine lining to grow over those raw surfaces. So when we think about the menstrual cycle, it's the exposure to estrogen. Estrogen is this blue line here. So the menstrual cycle starts on day 1. And then we see this rise of estrogen, which causes the uterine lining to get thicker and thicker and thicker and thicker. And then with progesterone, that lining sort of matures and stabilizes before menstruation. So what I do at surgery is I give these patients estrogen only for about 2 weeks, because estrogen is the great healer of the uterus. And so while the stent is in place, they're on estrogen. They're also on some antibiotics to prevent any infection, but they're on estrogen to build that lining. And then we can never give someone estrogen alone. We always have to give progesterone as that second hormone. And then we give progesterone plus estrogen for 10 days. They then stop everything and get a period. And then usually with that period, we'll do a repeat sonogram or some sort of imaging to see, is the uterus back to a normal shape? Have the adhesions really healed? The majority of patients will have their adhesions fixed about 70% of the time in one surgery, but there's a number of patients who need a second or a third procedure to fix all the scar tissue. So some patients are needing to come back for some repetitive procedures to make further progress. Majority of patients, like 95%, this is fixable within 3 surgeries, but it's a process. All right, moving topics. Any questions about hysteroscopy and some of the things that we do to fix the inside of the uterus? We're going to move on to laparoscopy, and just a few of, in this part shorter, but just to go over some of the conditions we fix inside the penis. So laparoscopy is a really cool, similar process where we're putting a camera usually through someone's belly button, because interestingly, the base of the belly button is an easy way to access into the abdomen. So there we put some gas, we have a camera with some light, and then we usually have 2 or 3 other instruments. And so these all go through what's called ports, which are these 5 millimeter incisions into the abdominal wall, through which we place like this plastic tube that lets us place in and out different instruments to do our work on the inside. And so we have gas that distends the belly, so we create space. And then we have light that helps us look down. And we're always operating usually from the belly button down into the pelvis to look at the uterus, fallopian tubes, ovaries. So the things that we might be doing laparoscopy for, one, we could be looking at someone who has a blocked fallopian tube or a hydrosalpinx. So on an HSG, here we can see a nice triangular uterine cavity. This fallopian tube is filling with dye and spilling down here, but this one is filling, and then it gets really, really big and swollen, and you don't see any dye coming out of this fallopian tube. So this is what a hydrosalpinx looks like, where the fallopian tube is dilated and really abnormal and blocked. We sometimes wonder if this is the case on ultrasound. Many hydrosalpinx can't be seen on ultrasound because we don't usually see tubes on ultrasound unless they're very abnormal. Here you can see like this is like almost looks like a little snake or a little worm, and this is what a fallopian tube will look like when it's swollen and full of fluid, is we'll start to see this kind of structure out by one of the ovaries. So some of these patients, again, have no symptoms at all, but some people have more painful periods when they have a blocked swollen fallopian tube. Some patients may have some more chronic pelvic discomfort. Some patients can have some irregular bleeding and spotting too. So here at surgery, so here we're looking inside the pelvis. This is a uterus. This is the left fallopian tube. Here's the left ovary sticking out. This is the right fallopian tube here. And one of the things we can do is at surgery, we can put some blue dye. So it's almost like doing an HSG, but an HSG, the radiologist puts some dye inside the uterus and takes x-rays. In the operating room, we put some blue dye in, like through the vagina, cervix, and into the uterus, into the uterine cavity. But what we care about is we're trying to watch that blue dye fill at the fallopian tubes. So here you can see there's blue dye going into the fallopian tube that's getting more and more swollen. So this is a very abnormal fallopian tube. I guess I don't have a picture of a normal one. But here, so there's blue dye here. So these fallopian tubes are normal. They're filling with this blue dye, and more importantly, you're seeing it. It's hard to see in this picture, but we're seeing it spill out the ends of the fallopian tubes. So those are healthy working fallopian tubes. So this one's really, really abnormal. So we know that a dilated swollen fallopian tube can like fill with all this abnormal fluid, which can be sort of toxic to implantation, toxic to an embryo. Can cause the uterine lining to be abnormal. And also a pregnancy can get stuck inside an abnormal fallopian tube, causing an ectopic pregnancy. So we want to remove this fallopian tube. Some patients need both fallopian tubes removed, and if you don't have fallopian tubes, then you can only really conceive with IVF, because fallopian tubes have sperm and egg meet each other. If someone has one healthy fallopian tube and one abnormal, we remove the abnormal, and there's still the option of natural conception through the healthy one, and the abnormal one is only causing problems and never being helpful. So that's one of the reasons we would remove a hydrosalpinx. So we do this procedure called a laparoscopic self-injectomy, which is removing the fallopian tube. So endometriosis is a condition that we run into a lot here, whether patients come to us because they have a known history of endometriosis, or whether we start to have that question based on someone's history of infertility, of pelvic pain, and sometimes certain cysts that we see on the ovaries. So this particular photo is showing a cyst of what's called an endometrioma. It's sort of a blood-filled cyst. It almost has like this ground glass appearance of how it's described. And it doesn't look like the typical blood-filled cyst that we see after ovulation called a corpus luteum. Those come and go. This endometriosis cyst, or called an endometrioma, doesn't usually go away. And unfortunately, they either stick around or they slowly get bigger with time. They grow inside the ovary. So the normal ovary is out, the edge of the ovary is out here, and it's just gotten stretched as the cyst is present. But patients who have endometriosis, they may have very painful periods, painful intercourse, chronic pelvic pain, bowel or bladder symptoms, because this condition of abnormal tissue causes inflammation and pain that can affect other organs and cause patients, some people just have infertility as their only presenting symptom. Some patients have no symptoms whatsoever. So here, when we're doing a laparoscopy and looking inside, so here's a normal uterus, and you can see like these strings of tissue. This is some scar tissue. Here you can see this is part of a normal ovary, and then there's this big sort of bluish colored cyst coming into the ovary. And then sometimes we see just these implants of endometriosis. So we look at this tissue called the peritoneum, which is the tissue here over to the wall of the uterus. And sometimes we see like these blue lesions. Sometimes we see some brown tissue, and this is what lesions of endometriosis can look like in adults. Like it can be blue or black, it can be brown, it can be lots of different colors. But this causes like inflammation and pain. And it also makes, can affect the ovaries, the quality of the eggs. It can cause scar tissue and make it so it's harder for fallopian tubes to pick up eggs. So there's a lot of reasons why endometriosis can impact fertility. But for many patients with endometriosis, sometimes they do better just doing IVF to get pregnant and bypassing all like any issues with ovaries, with egg production, with the health of the fallopian tubes. So not everyone who has endometriosis needs surgery to fix it as part of treating infertility. We fix it for patients who have a big cyst and we just can't do IVF with that big cyst present. We do it for patients who have such significant pain they can't keep having periods each month. So those are some of the patients who actually need surgery as part of their infertility treatment. Many patients, we suspect endometriosis. In fact, more of our patients have endometriosis than might actually have a diagnosis. But our fertility treatments tend to be better at helping someone get pregnant than surgery alone. And then we see a lot of different ovarian cysts. So here, looking on ultrasound, so before I mentioned that anything that's like pure black on ultrasound is just fluid filled. So this here is a fluid filled cyst within the ovary. And again, the ovary just gets stretched out around the cyst. This here is more of a hemorrhagic cyst. This is what we see from either just a blood-filled cyst that forms or one forms after ovulation. You can see it looks different than this endometrioma, which looks sort of hazy and it looks the same all the way through. Here, this sort of looks a little lacy. And like this corner is where there's a little bit of a blood clot as part of this hemorrhagic cyst. And this corner where it's more black is more fluid-filled. And these cysts tend to go away. And then this is what we call a dermoid cyst, which has like this, so it's this whole structure here. It looks like one of those New York City black and white cookies. Part of it here is very bright white and what we call echogenic, which is because of the nature of the cyst, it has some denser tissue. And then part of the cyst is sometimes just fluid filled, which is this black. And these cysts don't go away. And these can sometimes stick around, but sometimes they can really cause some pain and discomfort for patients. And when they're larger in size, because cysts put an ovary at risk of twisting on its blood supply. We sometimes are removing larger cysts for some patients. So here what you're looking at, so this is a healthy uterus, healthy right ovary, healthy fallopian tube. You can see how this ovary is huge compared to the other normal side. And what we do when we're removing a cyst from an ovary is we make an incision just in the ovary and we just shell out the cyst. So here you can see the cyst is here. Like this is all normal, healthy ovarian tissue that's going to shrink back down to that of a normal ovary after we take this out. I explain this to patients. It's almost like a water balloon inside the ovary, where the water balloon has a wall to it. It has contents on the inside, and as it grows within the ovary, it just stretches the ovary out. But you take out both the wall, like so the balloon part of the water balloon, and the contents, and then the ovary will shrink right back down. And then, so this is what we also want to prevent. So here you can see this is someone's ovary, and you can see that there's a corkscrew here. So this ovary, possibly from a cyst, has twisted on its blood supply. So when patients call and tell us, this rarely happens with IVF or after IVF, that they're having the worst pain they've ever had in their lives. Nausea, vomiting, like the first thing we worry about in someone who has a cyst or has these big enlarged ovaries is this risk of ovarian torsion. Our patients are definitely at risk of this from, just the stimulation of fertility treatment or because they have a cystic baseline. The ovary, when this happens, it literally causes the worst pain of someone's life. And it's usually on the left side or the right side. And the ovary can only survive having its blood supply cut off for about 24 hours, after which the ovary becomes like purple. So here you can see it's much more purple. It's like congested and it's not getting good blood supply. These are ovaries that can often be salvaged, but sometimes the ovaries are like all of a sudden just like black and dead. And that's what we want to prevent. So patients who we worry about having acute onset pain and we're worried about torsion for them, like need to come in for early evaluation or go to the ER. Again, the doctors will be engaged in this part of the conversation, but these are conversations that are super time sensitive. If patients call you and are like, all of a sudden I woke up having the worst pain of my life, I'm throwing plus or minus nausea, vomiting, whatever. Like those are concerns that need to get escalated ASAP, because this is one of the things we're worried about.
What's the treatment for ovarian torsion?
Great question. So it's surgical. So these patients, so we basically go in and we untwist the ovary. And once the ovary is untwisted, like usually the blood supply returns. It's like you breathe the sigh of relief because you know the ovary is happier. Even if this ovary looks close to dead, we still usually untwist it and save it because the ovary has some resilience to it. It has blood supply from more than one place. And so usually just the untwisting is the goal. And then give it some time. And usually we'll start to see the color return. Rarely does somebody need to have that ovary removed. And that's always our goal, is to figure this out ASAP, because we know if we think someone has torsion, the clock is ticking to get this figured out and have emergency surgery if necessary.
Could you just tell people like 72 hours later? That's like,
It can be. So like I operated on a 10-year-old a few weeks ago who had a twisted ovary. She'd been having symptoms for months. So it's unclear if she had a cyst on that side. If she was like twisting and then untwisting and twisting and untwisting. I heard about her on like a Friday. I took her to the OR the next week because she was feeling fine. But her ovary was partially twisted and she was probably living with a partial twist that would get like a little tighter and she'd have pain and a little looser. And her ovary was still healthy. But, you know, it needed to be fixed based on her symptoms, and we knew she had a cyst. So sometimes these ovaries have some resiliency. So yes, this requires like a plan to figure out what's happening and get this treated. All right. So bottom line, the goals of reproductive surgery: diagnose and treat conditions that can affect fertility, treat causes of abnormal bleeding and pelvic pain. So some of the symptoms our patients may come with. We always want to be improving and or preserving fertility, protecting the ovaries from risk of torsion, as we just talked about, which can be like both diagnosing and removing cysts, particularly cysts that are greater than 5 centimeters, increase someone's risk of torsion. So you'll see lots of patients with 2 and 3 centimeter cysts, like that's a normal follicle size at the time of ovulation. That's fine. But someone who's walking around with an 8 centimeter cyst that's been there for a while, like that's someone where we have to worry about, like, should that cyst be surgically fixed as part of their treatment? And we know that, again, these big IVF ovaries can be several times the size of normal. So it doesn't just have to be one cyst that's really large, but if someone has multiple 2 to 3 centimeter cysts on those ovaries, and that ovary is now multiple times the size of normal, that increases the risk of torsion. And then my goal is always to get patients back to their infertility treatment ASAP. So get them in, get them figured out, get their surgery done, and then back to their original provider to keep going. So this always can take some time out of the fertility treatment, which is very stressful for patients, but they also know that we need to fix this as part of, you know, hopefully helping them increase their chances of pregnancy and a successful pregnancy. All right. That's it. This is my crew. This is, so my husband Larry, me, my 6.5-year-old William, who met his first grade teacher bright and early this morning. We were at Yellowstone National Park last week. So this is the geyser. And so funny, this picture looks like smoke is coming out of my husband's head instead of the geyser that is just behind us in the picture. And my golden doodle Rocky, who was my first baby. She's 9. So this is the crew I go home to at night. Any questions that anyone has, either in the room or over Zoom? And I'm always around for questions. I'm here Tuesdays and Fridays. Those are my days when I'm physically here.
Question: what is like the largest environmental cause of like the polyps or the fibroids? Like, are there something in like a woman's environment that can kind of cause those things, other than like the overgrowth of the lining or the muscle?
Great question. So I don't think we totally understand why polyps and fibroids grow. We know that some people are at higher risk of polyps growing when they're just like women who don't have regular monthly cycles, who aren't shedding their lining each month. Some of those patients are at risk of just this overgrowth of the uterine lining developing polyps. Both of these are just so common. There's tons of research out there to better understand why fibroids grow, and there probably is some genetic predisposition. We know that African-American women have a much higher rate of fibroids than women of other ethnicities, but we know that women of all ethnicities are at risk of fibroids, but there seems to be some probable genetic factors that weigh in. And it's sort of these lots of different growth factors that are present that make fibroids grow. But again, like no one's been, like we know that they're also fibroids have some hormone sensitivity because we see them grow in women's reproductive years, and not before puberty, and they definitely don't seem to grow after menopause. So there's definitely some hormone part of the component of this, but no one has said, oh, it's like, plastics or like estrogens in our environment or other things specifically, but we know that all these environmental factors seem to have some impact on health in general. I don't think we've figured that out yet. Any other questions? Yeah.
What are the most common surgeries that you're doing on your adolescent population?
Great question. So when I'm operating on adolescent girls, I am fixing usually ovarian cysts. I am treating pelvic pain. So patients where we think that they could have endometriosis and they have pain, where like medical therapy, birth control pills, and things like that isn't helping. I also treat some patients for congenital anomalies of the reproductive tract. So there are abnormalities of both the uterus and the vagina that can lead to blockages of menstrual blood and significant pain that need fixing. And I see a bunch of patients who can't put a tampon in. And we find out that at their hymen, the opening of the vagina, there's extra tissue present, which is just like the way their body developed inside their mom as well. It's different than these other congenital anomalies, but I do a lot of procedures to fix both, like either a condition called a vaginal septum, where someone has extra tissue in the vagina. That can also be found with some of these uterine anomalies, but also extra tissue with the hymen. So I would say those are the most common things that I'm operating on for adolescents. I don't do a lot of surgery for the younger population. Most don't need anything. Sometimes I need to just examine them under sedation if like the little girls, I can't figure out if they're having like bleeding or discharge or something weird, but it's usually more the adolescents. Awesome. Thanks for your time and attention. It was a pleasure meeting those who I've not met before. And again, if you have any questions, I am found.
Thank you so much.
You're welcome. Super helping.